Dr. Madri, you start the things.
Yeah. Welcome to the ISA National PG online classes. So I request the moderator, the coordinator for today's session, Dr. Ira Dhawan, to please start the proceedings. Dr. Ira?
Good evening, everyone.
Ira, your connection is fine?
Audible?
Audible, I think, is breaking in between.
I think there is some problem with her bandwidth. Till then, I think Bajwa sir can give can just take over and give an introduction to the session.
Thank you, Dr. Madhuri. I welcome everyone in this online class. Today is a Tuesday rather, because yesterday, Monday, it was a Christmas day, but we didn't want to miss the class. So we have postponed it for the Tuesday. And I heartily welcome our past president and academic chair, Dr. Bhimeshwar sir. We should start with his words of wisdom for the class before proceeding further. Bhimeshwar sir.
Yeah, thank you, Dr. Baj and Dr. Madhuri. Wonderful sessions being conducted every week by the Honorary Secretary for all the postgraduates, and topics being selected are wonderful. Even last week was also wonderful. And this week, selecting a topic of trauma and from the Department of Emergency Medicine from MS Ramaya, and selecting Dr. Ramesh, Arna Ramesh. For this is one thing which the postgraduates should not miss at all. In fact, all the classes are being meticulously planned and selected by Dr. Bajwa, in spite of his very, very busy schedule in his hospital, as well as for the ISA itself. So I really thank Dr. Bajwa for continuing this wonderful sessions, and I wish this session all success. Thank you very much.
Thank you, sir. And I'm always very privileged to have you with my side. For the last 1 year, it was very easy for me to conduct the academic session, and this year also will go in the same way. And so with your blessing, we will have many academic projects lining up, and those will be starting very soon in the new year. And coming to this emergency medicine class, and I had a long association with Dr. Arna Ramesh now, being an emergency medicine specialist, is close to my heart, and being an emergency medicine person. So it's a very close topic to my heart. It was required, but the only thing was the classes were so much, gathered up, so it was difficult to give a slot. But airway management in trauma is one of the most dreadful topic, practically. Theoretically, you can come out with so many options, but the time you arrive in the emergency and the time that you see the patient, all the maxillary, different type of leaf out fracture, the bleeding, then the vomiters, then the loss of consciousness, then the panic in the room, it's very difficult to manage. I think today we are very lucky to have Aruna madam and her department and the students also to present these cases and their management. So without wasting time, I request Dr. Ira to proceed, Dr. Ira and Dr. Veda to proceed forward with the introduction of the moderators, the teacher and the students. Please, Dr. Ira.
Good evening, everyone. A very warm welcome. Apologies for that glitch. And on behalf of ISA, I wish you all a very belated Merry Christmas and a very Happy New Year in advance. And before we begin the academic session, we should pay tribute to Ma Saraswati, the goddess of knowledge.
Jaya
I welcome you all for this academic session, and it's my proud privilege now to introduce our today's chairpersons. For today is Professor Aruna C. Ramesh. Ma'am does not need any introduction. She is Professor, Head of Department Emergency Medicine at Ramaiah Hospital. She is also the State Advisory Committee in the Disaster Management member. She is Ramaiah's ATLS Site Director, AHA Regional Faculty, Medical Skills Lab Coordinator, Heart Rescue India Program Director, Bangalore Honorary Distinguished Faculty Member from the University of Illinois, Chicago, Honorary Officer Commanding Casualty Services, Civil Defense, Bangalore. In a career of spanning 3 decades, she has spearheaded change within herself and the institution, and having worked for a decade, more than a decade as an anesthesiologist and more than 15 years in the accident and emergency services, and now she's heading the Department of Emergency Medicine. She has taught and guided numerous undergraduate and postgraduate students and established the accident and the emergency departments in the state and the country. She's won numerous awards and has established and emphasized and expanded numerous training programs, including the IV therapy course, the basic trauma life support, which was one of the earliest forms of trauma courses, followed by the international trauma life support, and now the advanced trauma life support. And in addition, she continues to lead the AHA courses for BLS and ACLS. She continues to lead the front in many national and international ICMR projects, and her contribution towards the capacity building and disaster management is acknowledged across the country. We welcome you, ma'am. And now I would like to request my colleague, Dr. Vedavani, who is Assistant Professor in Pinamani Siddharth Medical College, Vijayawada, to introduce the moderator for today's sessions.
Good evening, everyone. Today's session will be moderated by Dr. Hari Prasad. Sir is working as Assistant Professor in Department of Emergency Medicine at Ramaiah Medical College. Sir is Fellow of Academic College of Emergency Experts India and a member of Royal College of Emergency Medicine and European Board Certified in Emergency Medicine. Sir have completed his postgraduate diploma in Medical Law and Ethics from NLS. His key area of interest are school CPR training, law and medicine, simulation in emergency medicine, and quality improvement. We welcome you, sir.
Thank you.
And this session is also moderated by Dr. Shruti ma'am. She completed her DNB in emergency medicine and currently working as assistant professor in Department of Emergency Medicine in Ramaiah Medical College for the past 4 years. Ma'am is also instructor of AHA, BLS, ACLS, and PALS. She is also course coordinator of PALS. And her key area of interest are pediatric emergencies and cardiac emergencies. Now I request the moderators to please introduce today's presenters.
Good evening, sir, and good evening, sir and ma'ams. It's a privilege for me to present here and moderate the session in the ISA meet. So the first case is going to be presented by Dr. Anjali. She's a year 3 postgraduate student in the Department of Emergency Medicine, Ramaiah. Over to you, Anjali.
Excuse me, ma'am. Meanwhile, I request all the participants to mute yourself while lecture is going on and videos off. We are live on YouTube at ISA National Headquarters. You can post your queries in the chat box, which will be taken up at the end of the session. All the lectures are available at ISA website. Thank you.
Good evening, everyone. It's me, Anjali, emergency medicine 3rd year resident from Ramaiah Medical College. Thank you. Shruti ma'am, can.
Yes. Go ahead.
Are you
Go ahead.
are you able to see the screen?
No, ma'am.
One second. Yeah. Now is it visible?
Yes.
Yes.
Yes, ma'am.
Anjali, proceed with the case.
Can I? Okay, ma'am. We got a pre-notification from ambulance driver that they received one male patient who was not wearing helmet and who had met with a road traffic accident, two-wheeler versus four-wheeler, and he sustained injury to head and face. He was unconscious and had history of vomiting of blood. They started on oxygen at 5 liters of oxygen with a simple face mask in the ambulance itself.
So according to you, what's the triage category for the patient and where the patient should be transferred?
And this is a red triage because patient has a dangerous mechanism of injury and it is a head-on collision and patient has unconsciousness and also has history of vomiting of blood. So it is a red triage.
And you want to transfer to a level 1 trauma center?
Yes, ma'am. Level 1 trauma center only we should transfer because all the trauma team will be available only in level 1 trauma center.
So why do you think pre-notification is important?
When we get the pre-notification, we can arrange for the trauma team as well as we can arrange for the airway equipments, other equipments, everything we can arrange in the meantime when the before the patient arrives in the ED.
So you can plan for the airway management, arrange for the equipment as well as call for the trauma code.
Trauma code also.
Okay, so who will respond to the trauma code? Who is going to respond?
Actually, there is a team of members. The team leader will be the emergency medicine consultant, followed by emergency medicine residents who will do the primary survey, and we have anesthetists who can manage the airway, then orthopedic doctors who can manage the pelvis as well as to rule out any bony injuries. Then we have general surgery doctor who can manage the abdominal part, that is to rule out any solid organ injury. Then emergency medicine nurses, 2 nurses are required, one for the patient care and other for the code red. And other one is the healthcare assistant who can help with the getting things.
Okay. This is for the chairperson, ma'am. What are the pre-hospital airway management recommendations?
So if you look at the multiple trauma patients, especially in the pre-hospital in 2016, in the European Journal of Trauma and Emergency Surgery, published in 2018, the recommendations grade of recommendations was A, and it said for multiply injured patients with apnea or agonal breathing or with a respiratory rate of less than 6, emergency anesthesia, endotracheal intubation, and ventilation must be performed in the pre-hospital setting. So, but then they went on to modify this with the recommendation of telling that it is better probably to avoid intubation in the pre-hospital if there is no qualified help available. So, especially considering the situation in India, what do you think, Dr. Shruti, should be our approach in the pre-hospital?
As you said, ma'am, the airway management program, the pre-hospital for the paramedics, so the pre-hospital airway management program doesn't train on rapid sequence intubation or suction-assisted laryngoscopic decontamination or video laryngoscopy. Therefore, there are less trained paramedics who are trained in intubations. So hence, the lower rate of intubations, pre-hospital intubations are present in India, in the Indian setting.
Okay.
So we'll move on to Dr. Anjali with the case.
We're able to see. It is going, go back
Yes,
to,
ma'am.
yeah. No, Shruti. It went through the slides.
I'll share it. Is that okay?
Yeah, I think so. You know where, which one it is?
Shruti, okay.
So in multiple trauma patients, what the modification also specified is that if there is hypoxia less than 90% saturation in the pre-hospital with severe traumatic brain injury with GCS less than 9, or when there is persistent hemodynamic instability and severe chest trauma and respiratory insufficiency, it is better to intubate the patients. But as Dr. Shruti said, in the Indian scenario, it becomes very precarious because currently the paramedic team might not be well trained, and as it is in controlled conditions itself in a polytrauma patient, we find it difficult to intubate and let alone in the pre-hospital. Go ahead, Shruti.
Anjali, you can continue with the presentation.
Unmute, Anjali. Go ahead.
Ma'am, can you hear me?
Go ahead.
Okay, we got a 26-year-old young male wheeled into emergency medicine department with alleged list of road traffic accident, two-wheeler versus four-wheeler. Patient was not wearing helmet and the accident occurred near to our hospital.
Was it
Go
trauma
ahead, Anjali.
called? Anjali, was a trauma code called?
Ma'am, trauma code we already announced, ma'am. Like we arrange for the emergency medicine consultant, then emergency medicine resident, then general surgery team, orthopedic team, and the anesthetist, as well as the healthcare assistants.
Okay, so what are the immediate life threat? Yeah, you can continue.
Okay, coming to the primary survey.
Go ahead, Anjali. What
Ma'am,
does
next.
the primary survey consist of in a trauma patient?
Ma'am, primary survey, ma'am, like ma'am, next slide, please, ma'am.
Now, what does the primary survey consist of? It consists of what you have displayed over here.
Primary survey consists of airway, breathing, circulation, disability, and exposure. So
what are the immediate life threat to the airway?
Here we have direct trauma to the airway and also to the surrounding structures, especially in the maxillofacial structure. And there is contamination of the airway due to debris such as vomitus and the blood. And there will be loss of pharyngeal tone due to head injury or GCS less than 8. And there is incorrect positioning because we can't hyperflex the neck, and midline manual inline stabilization is required for this patient.
So why do you need a specific person to manage the airway, a specific doctor to manage an airway?
Because the airway doctor is typically responsible for assessing the airway, the anterior neck as well as the GCS. Their goal is to ensure and maintain a patent airway though the patient can be successfully oxygenated. Coming to airway and C-spine control, this patient airway was threatened with oral bleed as well as deformed face. So interventions, we did an open airway with jaw thrust, suctioning was done, and OPA was inserted. C-collar was placed, and we planned for intubation, but we anticipated for difficult airway.
So there is a request, Anjali, that you are a little fast in speaking. So can you be a little more slow in what you're telling?
Yes, ma'am. Yes.
So, Dr. Shruti, is the procedure of focused intubation imperative here in such situation of polytrauma involving facial injuries?
So ma'am, focusing on just getting the tube is diverting the attention away from the physiological principles of oxygen delivery. So the ABC ABC priorities of trauma resuscitation are going to be stop the bleeding, maintain perfusion and oxygenation. Hence, life-saving oxygen maneuvers may include a jaw thrust maneuver or bag mask ventilation, insertion of a supraglottic airway device or intubation. So advanced doesn't necessarily mean better.
Okay, so
That's
you
what I
mean to
think.
say that oxygenation becomes important along with ventilation? And
Yes,
the
ma'am.
golden
Yes,
rule
ma'am.
of ventilation says anybody almost can be oxygenated. That is going to be most important. And also ventilated using the bag mask ventilation in most of the circumstances. So the art of bag wall mask ventilation, I think, is emphasized in the emergency medicine department because it might take a little while for the airway team, advanced team to actually arrive in the emergency room. So the skill of manual ventilation with proper equipment is the fundamental learning that has to be there for anybody who is going to be doing the management of airway.
Yes, ma'am.
So Anjali, go ahead. Go to.
Coming to breathing and ventilation, our patient was tachypneic with a respiratory rate of 30 per minute and saturation was 80% with 5 liters oxygen. And there was a right-sided chest bruise was present with bilateral air entry was equal. So we started on oxygen at 50 liters per minute via NRBM and ABG was drawn at this level.
So the patient is tachypneic, respiratory rate of 30, 80% in oxygen. What else you want to, see in this patient at the breathing level?
We should rule out any other injuries like tension pneumothorax or open chest wound. If there is a tension pneumothorax, we should first do needle compression followed by chest tube insertion on the affected side. If there is a pneumothorax, prepare for the chest tube insertion on the affected side. And if there is an open chest wound, first we should seal the wound with an occlusive dressing and tape on the 3 sides. Prepare for chest tube insertion on the affected side. If there is a pulmonary contusion, prepare for the early intubation and mechanical ventilation. If there is a flail chest, prepare for intubation and ventilation. If there is spinal cord injury, then we should avoid hyperextension or rotation of the patient's neck. And spine immobilization should be done. Monitor for signs of distributive shock. And if there is a decreased level of consciousness, position the patient's head midline with the head of the bed elevated. Anticipate a CT scan and implement intervention to prevent aspiration. If there is a massive hemothorax, prepare for chest tube insertion on the affected side. Administer blood and blood products as ordered, and anticipate and prepare for emergency open thoracotomy. Meanwhile, we got the ABG done. And it shows a respiratory acidosis with pH of 7.18, PCO of 59.8, PO of 39.7, bicarbonate of 21.8, and lactate of 3.06.
So hypoxia and hypercarbia is not good for trauma, right?
Yes, ma'am.
So what airway difficulty did you anticipate for this patient? In this patient?
Difficult airway.
Just before you proceed, Dr. Hari, do you want to comment on this blood gas?
Basically, the blood gas, in addition, this shows a mixed acid-base disorder. As you can see, there is an element of lactic acidosis. Adding to that, you have a respiratory acidosis component. So this is bad, very bad physiology, especially for someone with traumatic brain injury. It will cause secondary brain injury in addition to negative effects on other organs as well. So this needs to be corrected immediately with appropriate ventilation.
Go ahead. Go ahead.
Okay. So we will get difficulty when we are ventilating with a back mask, and we will face difficulty in laryngoscope as well as while intubating also we will face difficulties. Coming to circulation and hemorrhage control. This patient had a heart rate of 110 beats per minute with blood pressure of 110/70 mmHg. But the peripheries were normal and warm. There was no obvious external hemorrhage. At this level, we secured an IV cannula and drawn blood for hemoglobin, PCV, renal function test, blood grouping and typing. Patient was started on IV fluids, 250 ml normal saline bolus, followed by infusion at the rate of 100 ml per hour. We ordered for bedside EFAST and chest X-ray.
So in a patient who is going to be hemodynamically stable, so fast might not be indicated in most of the patients. So we might do a fast scan only during our secondary survey. So when there is an indication for doing the fast scan, especially in the primary survey, would be when there is persistence of hypotension. What would you say, Dr. Hari?
I agree, ma'am. So indications, FAST has a benefit of ruling in hemoperitoneum or a pneumothorax or a hemothorax, but it cannot rule out. So in a hemodynamically stable patient, it doesn't offer. So one should not use that and impede other interventions which are much more important.
You can go ahead, Anjali.
Okay. At the level of disability, patient GCS was E1, B1, M4. Pupils both eyes 3 mm reacting to light. With GRBS of 157 mg per deciliter, there was no lateralizing signs. This level we planned for CT brain and we started on neuroprotective measures.
Go ahead.
Difficult airway in back ventilation includes upper airway obstruction, lack of dentures, beard, mid-facial smash, facial burns, dressing, scarring, poor lung mechanics.
So
in
what? Yes, ma'am.
in this patient, Anjali, go ahead, because there's a short time period, so you need to go on moving fast, going answering. In this patient, what was the obvious things that you noticed that might interfere with your bag mask ventilation?
This patient has a facial deformity, ma'am, and so we can't fix the mask properly.
So you mean to say that patient had an upper airway obstruction because of the blood that was there in the airway, and also because of the injury to the midface, that you might find the bag valve mask ventilation difficult?
Yes, ma'am.
And we could also think because of the hypoxemia that there might be a lung issue involved, either aspirate
lung
or
brewing
contusion.
also there.
Yes. Next, proceed.
Difficult airway in laryngoscope includes short, thick neck,
You
receding
just
mandible.
focus on the patient, on this patient, what the patient had.
Patient, since it is a trauma case, there is limited head and neck movements, so there is difficulty in
So there is
laryngoscopy.
difficulty in laryngoscopy because of limited head and neck movement of this patient.
And we arrange for the difficult airway cart. It includes multiple blades and endotracheal tubes, stillets and bougie, then a laryngeal mask airway, cricothyroidotomy kit, and ETCO2, and fiber optic laryngoscopes also. We prepared for rapid sequence intubation, which include the steps like pre-intubation assessment, pre-oxygenation with 50 liters O2 for 3 minutes, and we prepare for the worst, pre-medication like fentanyl, lidocaine, and paralyzing agents were arranged, and pressure on cricut, place the tube, and post-intubation assessment was done. This patient rapid sequence intubation was done using, and intubation was done using 8 mm endotracheal tube and fixed at the 22 centimeter, and tube position was confirmed with 5-point auscultation, and then it is connected to ETCO2. Then we connected to the ventilator in CME mode, and PEEP was 5 centimeter water with a respiratory rate of 12 per minute and FiO2 of 1. Then we provide with adequate analgesia, sedation, and paralysis.
So this is one of the component of the neuroprotective measures which we have to take in a traumatic brain injury.
Coming to exposure and environmental control, we can see there was a full thickness laceration of the left alar region, philtrum, upper lip and lower lip with active bleeding. There was no obvious long bone injuries. Body covered with blankets, and AC switched off to prevent hypothermia in this patient.
So at this point, what factors predispose the patient to hypothermia, and what interventions you are going to take to prevent hypothermia in this patient?
Because if we didn't cover the patient with blanket, patient will go to hypothermia. So we should tell sisters to cover the patient with blanket as well as to start on warmers.
Warmers, bear hugger, start on warm IV fluids.
Warm IV fluids.
Also, don't forget to put off the AC. It is said that you should be warm enough. So then only the environment is warm for the patient. So hypothermia is something that we all dread in trauma patient.
Meanwhile, we got the chest X-ray done, and there was no rib fractures, no pneumothorax was there, and EFAS was negative. The ECG shows sinus tachycardia. Meanwhile, we got the CT brain plane done. It shows left parietal traumatic contusion with left temporal traumatic subarachnoid hemorrhage. The CT C-spine was normal. CT phase with 3D reconstruction shows right parasymphyseal coronal process of the mandible fracture, and all valves of maxillary sinus fracture with hematoma, fracture of the medial pterygoid plate, and bony septum. In this picture, we can see those fractures. Coming to the secondary survey, patient doesn't have any history of allergies, not on any regular medications. There was no history of past surgeries or illness. Last meal, drink, stool, urine was not known. Patient was brought to the Ramaya Memorial Hospital directly after the accident. Coming to head-to-toe examination, in head there is a right occipital hematoma approximately measuring 3 into 1 centimeter. Face there is soft tissue defect of over lateral aspect of the left eyelid and left eyebrow, full thickness laceration of the left alar region, philtrum, upper lip and lower lip, left periorbital edema, and multiple abrasions over the face was present. C-spine and neck, there was no external injuries. Thorax, there was no external injuries. The bilateral air entry was equal and there was no added sounds. Abdomen and pelvis was soft with no external injuries. Extremities, there was no external injuries or deformity present. So definitive treatment done by our plastic surgery team, open reduction and internal fixation with arch repair, soft tissue repair done as an elective procedure as well as tracheostomy was done.
This is to the chairperson, ma'am. So why do trauma patients die?
Yeah, if you look at the whole situation starting from the pre-hospital, where actually Adam Coley says that when an accident happened, your survival depends on which hospital you're taken into. And most of the time you're taken to the closest hospital, and that hospital might not be the best hospital. So what he means is that even in the pre-hospital, the people who actually trial the patients and shift them might be shifting to a lower level hospital. And in that level hospital, you not only are ending up in a wrong hospital, and where the team is not prepared to take care of this severely injured patient, but also that means a team means that there is no specialist who can get in a definitive airway, but also it means that we need to ensure in the pre-hospital the training is given appropriately for each of them to decide on which hospital the patient has to be taken into, from level 1 hospital where all type of specialties will be available to the lower level hospitals where immediate bleeding can be addressed. So there might be nobody protecting the airway, where simple maneuvers like patients like opening the airway, doing a jaw thrust, or inserting the oropharyngeal airway in case the patient can tolerate and does not have a gag reflex in the pre-hospital, clearing the airway using an appropriate suction. Yes, that is what is going to be protecting the airway. One should not be trying to do too many maneuvers. That is what the ATLS guideline is. If the patient is actually breathing spontaneously, it is better to provide oxygen and ship this patient to the closest hospital possible. And if we see that most of the time the care is being given by inexperienced people, so that's the reason that when they get shifted to the higher center or tertiary center, we see the delay in time and the delay in the golden hour. And again, if you look at the golden hour, it is not a fixed time window, but it is a window of time that is giving us the space to actually take care of the airway breathing and the circulation, and also control the hemorrhage in these patients. And we should always have senior help available. And most of the time when the arrival is late or senior help is not available, the more appropriate care to these polytrauma patients is not provided. So in the wider sense, if you see, ATLS says we need to treat the greatest threat at the earliest. Most of the time in ATLS, it also treats you that though you approach a case vertically or in one after the other, like airway, breathing, circulation, but most of the things occur horizontally. So somebody is taking care of the airway, and that somebody should be a specialist who has actually done more than 20 to 30 intubations in the past 1 year, and who is capable of handling the airway and taking the decision to actually manage the airway in case the intubation is not possible in the first attempt, and go on to up to the surgical airway. They should have the capability of doing in this patient who has polytrauma and airway issues. And then time is of essence, because time is clicking, and these patients, we should understand that in our emergency room, or in every emergency room across the country, our aim is to ensure this patient reaches the definitive care area within 1 hour in stable patients, and in unstable patients our time frame comes down drastically. So probably as soon as we identify that there is an uncontrolled hemorrhage, we will be shifting this patient to the OT directly. And the main thing is, the dictum is to do no further harm. So we have to know our limitations. So if we do not know how far we can go, then it becomes very difficult. So it is very important that we need to limit our interventions to our capacity and call for help very early. So this is what is the statement of today's polytrauma. And if you see, the entire thing that happens over here actually happens in real time in very less time. And the patient will be in the CT room within 10 to 15 minutes when the team works together. Shall we move on to the next case?
Ma'am, Dr.
Yeah.
Raghuvandan has a
Yes.
question in the chat.
Yes, please.
Dr. N. Raghunandan, sir.
So his question.
Ma'am, yeah, ma'am. Regarding the ATLS guidelines, when we come across a polytrauma, the main importance should be on the teamwork, ma'am. I believe once the patient comes in, you have to take up the first primary survey, act on the, as this is a case of oropharyngeal injury. So handling the airways of utmost importance. We should make sure that we don't worsen up the airway and try to get a definitive airway device in place and start mechanically ventilating. Since the indication for mechanical ventilation is poor GCS levels, hypoxia, your ABG findings. I think ABG report, if at all it has come, it is good. Even if the ABG report is not there, it's better to go for intubation and get the patient mechanically ventilated, then go for anti-edema measures. And as you told, EFAST in this scenario, I don't think will be of any help in the primary survey. Secondary survey, once the patient is little bit stabilized and we have a team across, then we can go for a EFAST. And the case scenario has been clearly explained in the PGs. It's a good work, ma'am. That's what I wanted to. It is teamwork that will help us, and teamwork is very important in emergency, because we come across many polytraumas where we may have blunt injuries, where the spleen there might be bleeding from the spleen because of road traffic accidents or head injuries. It is multidisciplinary, and the PG should understand that they should call for help. Call for help should not be at the second stage, at the primary stage. Once you see the primary survey is done, the immediate call for help should go, ma'am. Thank you.
Thank you, Dr. Raghunandan. Yes, that's the important message. And if you see, most of the time, there will be faculty available at the who will be responding or on the floor of most of the emergency department. If the emergency department is not responding, then of course the anesthetist will be taking the lead role and will need to respond and have other people come in. When they are acting as team leaders, they won't be able to take care of the airway because there will be many other aspects that they will need to concentrate on. So you will require another team member to be coming and taking care of the airway. Dr. Hari Prasad, any thoughts?
No, ma'am, I agree with Dr. Raghunandan and Dr. Navboth. As ma'am said, I think teamwork is most important, and it's not about whether I can do it myself. It's about doing what's best for, because everyone gets pigeonholed into their own role. So someone has to take the role of a team leader. If the ER physician is there, they take. Otherwise, I think if the hospital doesn't have an active emergency department, I think the anesthetist should take the lead role. In addition to managing the airway, played the role of a team leader as well. So ATLS goes a long way in training the doctors to be team leaders. So I think that would also help.
As Dr. Raghunandan is stressing on calling for help, yeah, code is already called. Before the pay, if we get pre-notification, code is already called and people are there available in the ER, actually waiting. Even the radiology technician will be there to do a bedside X-ray. So people will already be there, even before the patient arrival. Many times the patient's arrival might be delayed and the trauma is announced. So people are going to respond in less than 5 to 10 minutes. So that is, once the code is announced, just like in code blue, the response for trauma also is going to be there.
As Sir said, EFAST holds good as a secondary survey in this patient because the patient is not in shock or something, or we are not suspecting any pneumothorax kind of thing. But in this specific case, he had a kind of bruise in the right chest. So there was availability of the ultrasound machine in our emergency department. So we had got a EFAST done. So what thoughts what thoughts do you have, ma'am?
No, the dictum is very, very clear that airway is something that you need to actually get into place. But this patient had hypoxia, probably had aspirated, and you needed to get the oxygenation up. And while the preparation is going on for a difficult airway, when you anticipated, even the plastic surgeon who had responded said might require tracheostomy for this patient. So EFAST is not a component that we will be considering in the primary assessment. And even after that, it might not, because we are taking for a CT scan, and a pan CT might be done because you need a C-spine scan for this patient and also a pelvic scan for this patient. So the abdomen also will get scanned in the pan scan that we usually do for this patient. So shall we move on to the second case?
Yes, ma'am. Any further questions can be posted in the chat box. We can discuss at the end.
Is the screen visible, everyone?
Yes, sir.
Dr. Tilak is our year 3 resident. He'll be presenting this second case, again, where we'll be highlighting the importance of airway management in trauma. Over to you, Dr. Tilak.
Tilak, unmute your. Is he there?
Bajwa sir, you'll have to make him co-host, I feel.
I've allowed everyone to unmute themselves. He's already.
Tilak, you are visible, but unmute yourself, please.
Yeah, sir, is it audible? Hello.
Yeah, we can hear you. Please go ahead.
Thanks. Okay, good evening, everyone. So myself, Dr. Tilas, here in the Department of Emergency Medicine, Ramaya. So in the previous discussion, we learned that we had difficult area and how to approach that. And also we studied up the golden hour and the importance of the team approach. I can say here is the door to the challenges, and most of the time the challenges are unanticipated. And with the continuation of the discussion with the previous class, we have the anticipated difficult area management. But adding to that challenge, we have the one more physiological challenge, and we'll face scenarios and how to handle the unexpected difficult area as well as physical difficult area. We had a case with the pre-notification of 28-year-old male, and where M stands for mechanism. The mechanism, so biker without helmet was hit to the truck and head down, and with the mechanism we can expect that is the eye.
Dr. Tilak, please slow down. Please slow down and speak clearly. You're very fast, please.
Okay. Oh, sure. So M stands for the mechanism. With the mechanism, we have the biker with the helmet lift the truck and head down from the back. And with the mechanism, we can anticipate that it is a high velocity, and we can anticipate the polytrauma and injury sustained to the head as well as face as well as forearm fracture. And it stands for the symptoms. Patient is drowsy but responding to pain as a morning, first like unit. And in the nursing home, we started on oxygen with a simple face mask at the rate of 5 liters per minute, and they started IV fluids at the rate of 100 ml per hour.
Dr. Tilak, at this point, where would you send this patient once you receive the pre-notification based on your ATLS triaging? So where should the patient go?
And injury sustained head and face. Yeah, red area, red area. So we'll try that to the, our triage code is right for this patient, and we'll ship the patient to the station day, and obviously we'll ship the patient to the level 1 trauma center.
Yes. So it has to be a level 1 trauma center, and within the trauma center, obviously, you're going to triage this patient, right? Good.
And as we had a clear information regarding the patient, so we knew that patient had a difficult airway management. So we alerted the trauma team. So where our trauma team consists of anesthesiologist who is experts in the airway, and the surgeon, and the air surgeon who is going to take care of the chest as well as abdomen, and the neurosurgeon who is going to take care of the head. And what our role is, we are as a ER patient, we lead that trauma team. And most important is the personal protection, since the trauma patients will be pulled in the blood. So our safety is most important. So we should get ready with the PPE, personal protective equipment. And so we should prepare for the both routine airway management as well as difficult airway management. And we should alert the emergency OT as well as IC, and we should alert so that such and situations are arriving to the ER.
Okay, at this point, I would direct to the chairperson, Dr. Aruna ma'am. What is the importance of a trauma team? I know we have spoken about it also in the previous session, but I think it has to be highlighted again, and how it impacts really the care of the multiple injured patient. Can you please highlight for us?
Yeah, for example, the airway, when a polytrauma patient arrives in the ED, the airway is taken care of the specialist team. And that best team is going to be the people from anesthesia, where they are handling the airway in and out every day. So it will be most appropriate for them to be responding, and then the emergency medicine team can forget about the airway, that it is being attended to. And then, of course, then comes the primary assessment by the emergency medicine consultant, and also or the resident who does the assessment. And at the same time, horizontal approach allows the trauma resident and or the ortho resident to look for the bony injuries and also the surgery resident to take care of any bleeding that they are anticipating. At the same time, the emergency consultant is trying to identify if the ventilation and oxygenation is optimal. If not, on how he will be able to actually address the issues. And at the same time, if there is continuing hemodynamic instability, we need to identify at the earliest what is happening in this patient. So ruling out tension pneumothorax and asking to do the fast scan as it is like a stethoscope in the emergency room. I think it hardly takes less than 5 minutes when we are activated and we have the machine on. It takes just about 5 minutes. Do you agree, Dr. Hari Prasad?
Yes, ma'am, agreed.
Fine, yeah. And the nurses all are trained, so they know on that they need to get it to large bore cannula in, warm fluids, fluid warmer, blood warmer, and in case we need to actually activate the blood bank and need more quantities of blood or massive blood transfusion code has to be called. I think it all occurs simultaneously and like clockwork.
True, ma'am. Thank you. Thank you for that. Moving on. Dr. Tilak, continue.
So, present on this, we had a donated ambulance and bring the patient to small nursing home, and we received the patient around 10th year. And
this we have already spoken
so
about.
Since
So
it is high velocity mechanisms,
go ahead, Tilak.
it is sure. And we'll assist with the horizontal respiration.
Yeah, I think Dr.
So,
Bam has already highlighted
what
yes. So we'll be proceeding with horizontal resuscitation. Thank you. So
coming to the primary assessment, so the looking at the patient had an acid breathing and the whole area was full with situations, and also patient had a facial trauma, deformed nose, right mandibular swelling as a deformity, and multiple ecchymosis. And so, as looking at patient as well as linked to the guidelines, we anticipated the difficult area. So first, what we did is we opened the airway with the help of Jacques manual and the oral contents section and the which and we set the oropharyngeal airway and we started hypoophagy at the rate of 15 liters per minute. And we assess the GCS, since it's horizontal assessment, we finally assess the GCS. GCS was 850, which was, and along with that, there was bilateral equally. Pupils were bilateral equal, that is 2 mm, and equally reacting to light, and there were no focal excites.
So, in this situation, Dr. Tilak, so what were the things which made you feel you could be dealing with a potentially difficult airway?
So one thing, so it is a trauma to the head as well as face. In the face, we noticed that there was a mandibular swelling and deformed nose. So with the mandibular swelling, there will be loss of normal structural support for the airway. So whenever a patient lies in a supine position, the airway gets compromised, and so patient will have the impending threatened airway. So with the loss of the normal
I think some network issue with Dr. Tilak.
Dr. Tilak, some network issue. Anyway, I think a quick summary. So I think what Dr. Tilak was trying to say is we call something a difficult airway for potentially anything that could be difficult. That includes a difficult laryngoscopy, difficult bag mask ventilation, difficult use of extraglottic airway devices, or a difficult cricothyroidotomy. So there are various mnemonics. I think most of you are already familiar. I'm not going to get into that. But what I would like to highlight is there is no perfect mnemonic. There's nothing which will definitely tell us that you're going to deal with a difficult way or you won't deal with a difficult airway. I think we're always safer to assume that every airway management in trauma is almost always a difficult airway in one way or the other. It might be during intubation or it might be after intubation. So a difficult airway should be anticipated. You should always prepare to fail. Otherwise, you're bound for failure. I think that should be the take-home message. In fact, now what is being really pushed forward is the Heaven criteria, which they say is combining all of the following, which is a summary of there is hypoxia, exsanguination, extremes of age, anatomical abnormalities, presence of fluid or blood. All of this put together, they form the Heaven criteria. But then all of this data, what it says is there's no perfect predicting factor. But I think one thing that you can always use is the Leon, which is basically Mallampatti cannot be done in patients of trauma because they're already on a spine board. So you're looking at the Leon, which is look externally, evaluate with the 332 measurement. Hello, can you hear me?
Yes, go ahead.
Right. So Leon technique would definitely go a long way. And in this situation, as Dr. Tilak was mentioning, you at multiple levels, you're going to have difficulty, whether it's bag mask ventilation, it could be due to inadequate seal. You could have difficulty performing laryngoscopy with the mandible fracture. Again, there are loose teeth. Patient could be actively bleeding from the oral cavity. So again, anticipating and preparing is the right way to go forward.
So, Dr. Hari, I would like to also add over here what Wall said in 2002, that the difficult airway is something one anticipates. The failed airway is something one experiences. But I think from what others have experienced and we learn, I think we need to avoid. Carry on.
True. Well said. Dr. Tilak, carry on.
Yeah, we decided to intubate. And while since we decided to intubate, we have to prepare for the anticipated difficult airway. And the preparation can be remembered with the mnemonic SOAP, where S stands for suction. In the suction, we have the ventures like R-tip suction, catheter, and the O stands for oxygen. We should have the continuous oxygen supply. And the A stands for airway devices. That is, we'll have the two different side ET tubes and some blades, both side and curved blades. And coming to the P, where P stands for the positioning. And in this scenario, since we are anticipating C-spine injury, we'll stabilize the C-spine with midline inlet stabilization. And where N stands for the medication. And in this scenario, we get ready injection agent, intermediate, relaxing agent, succinylcholine, as well as post-intubation medication as pecuronium, as well as fentanyl. And coming to the equipment, we kept the ventilator ready, as well as continuous end-tidal carbon dioxide CO2 monitoring. So
before you move on, Dr. Hari Prasad, would you like to emphasize on the oxygenation techniques that we use in patients who undergo rapid sequence induction and also in polytrauma patients where hypoxia can be triggered off when there is even minimal gaps that occur before intubating the patient?
So, ma'am, thank you. So in any patient of polytrauma, you're anticipating that the stomach is full. So we proceed with the rapid sequence intubation, where largely a non-rebreathing mask at 15 liters per minute, making sure that the mask has an adequate seal. Prior to that, it's very important that you clear the airway and provide jaw thrust. And if you feel there is an, as in this case, there was gurgling was heard, if the patient can tolerate an oropharyngeal airway, that should be placed. Ensure anatomical patency and then start the pre-oxygenation with NRBM. However, in situations apart from trauma, other ways of pre-oxygenating is, of course, the time-tested bag mask ventilation is the best one because some positive pressure is also given through that. In addition to that, in other medical emergencies, of course, now NIV can be used for pre-oxygenation and HFNC also can be used. But as far as trauma is concerned, I think NRBM at 15 liters per minute gives you just enough denitrogenation and buys you the time to proceed with RSI. However, at some risk, so that coming to that, I revert back to you, ma'am. So preparation, specific preparation, I think basic things I think Dr. Tilak mentioned, but what's your fallback technique? So if something doesn't work, you need to be prepared for your plan B and plan C. With regard to that, how do you prepare, ma'am?
Yeah, I think you have actually put it up saying that in addition, I also would have put if high flow nasal oxygen is not available
Apneic oxygen also.
in most of the places, but nasal prongs can still be used in these patients. So that is one thing that we do. But for that, you require two sources of oxygen to be available in, and many times even in the trolleys, the oxygen cylinder will be there and the wall source also will be there. So I think we need to improvise and ensure that the oxygen is going in these patients. And of course, as you say, plan A is always, one can plan to go ahead with the usual laryngoscopy where you would have checked the two blades and kept it ready. And also difficult intubation, you get all the other types of blades if it is available, but many places it might not be. But we go ahead and keep, but video laryngoscopy in airway trauma might be dicey because it might flood the view with blood. So again, you might it might hinder your intubation. But having a help of an equal a person who is equally qualified or more qualified is definitely going to help. And with the burp also, in case you cannot visualize. But the manual inline stabilization with many people around the airway, it might be difficult to actually intubate the patient. But then again, one can use a video laryngoscopy, and if that also is not working, we go ahead and actually ensure that oxygenation is there throughout the procedure of attempt. And worst scenario, we can insert supraglottic airway device, because you've got various supraglottic airway devices, and also the eye gel in case you find that there's not enough space and you just want to slip in. And there are 3 ways of introducing the eye gel also. But again, all these are not going to definitely protect the airway, and it is going to be only to buy the time. But if you think that we need to go ahead and get a definitive airway, we are unable to ventilate, we are not able to oxygenate this patient, then we might have to go in for an emergency cricothyroidotomy. Yeah.
Thank you, ma'am. Thank you for the extensive explanation. Moving forward, so let's assume that the team, the airway operator, is getting ready to prepare. So, Dr. Tilak, proceed with your primary survey.
So, as we discussed before, we are assessing we are approaching with the horizontal precipitation. So, in the breathing, patient was dyspneic, but on oscillatory, there were bilateral equal chest air entry was there, and especially equal chest movements were there. And patient had a respiratory rate of 32 cycles per minute and maintained saturation of 97% and 5 liters of O2. And in this level, we interviewed the help of oxygen with non-repeatable mass at the rate of 50 liters per minute while preparing for the difficult intervention. And if you notice, we have the issues like tachypnea, but we can rule out any chest or blunt chest trauma like mentioned pneumothorax or hemonemo. Clinically, there are no any clues suggesting a hemonemo or tachypnea. So moving ahead with the circulation. So there are cool peripheries. Peripheral pulses are stable, no obvious visual source of external hemorrhage, and both S1, S2 sounds were heard, and it was not muffled. And patient had a heart rate of 130 beats per minute, and BP was 80 by 60 millimeter of mercury. And at this level, we secured the large 2-bore IV cannulas, and we drew the samples for the hemoglobin, packet cell volume, and also blood grouping as well as cross matching. And so we started war fluids as well as according to the Class trials, that is one of the steroids in the trauma. We gave the injection taraxine acid 1 gram over 10 minutes, followed by 1 gram over 8-hour infusion. And also, so samples was gone for the acid as well as acid plus analysis to look for the lactates as well as base deficits. Since after the fluid resuscitation, we reassessed the patient, but the BP was improved to just 90 by 60. And since patient was a transient responder, always we should look for the source of the bleeding with the help of the diagram. So when you know, I mean, if you look at the right side of the slides, we have the blood on the floor, that's 4 more. So blood on the floor is nothing but there are no in the 4 more. So these are the sites where in the human body where we can lose the lot of the blood. So in that so most common is the chest, followed by the abdomen and the pelvis as well as long bones. And since like for the chest we plan for the X-ray, and also for the abdomen we plan for the extended talk. And
yeah,
so
Tilak,
the
your voice is breaking. I think a quick summary. I think what Dr. Tilak was trying to talk about was blood on the floor and 4 more. Blood on the floor is external bleeding, which was not there in our patient. The other 4 areas were chest, which was less likely. We didn't clinically have anything suggest to have hemothorax, nothing suggesting cardiac tamponade, and there was no obstructive shock, no pneumothorax. So we were considering blunt abdomen trauma, and pelvis deformity was not there. So we proceeded with the fast. Dr. Tilak, would you like to comment? This was our extended fast.
So when you look at the right side, so the left side is normal, and you can notice the ALS. It indicates there is.
I think he's having issues in the.
Similar by like hemothorax.
Go ahead
Yeah,
and
so
explain.
quickly, just to reiterate what Dr. Tilak was saying. So what you're looking at is a normal lung sliding, which essentially tells you that there is no pneumothorax, at least in the view that you are seeing. Will it tell you 100% that there's no pneumothorax? Less likely. Again, this is going back to the discussion what we already had. I don't want to repeat that, but this gives you some indication that at least a significant pneumothorax would have appeared and prevented the lung from sliding in this manner. So the shimmering line, what you're seeing is a normalcy. Continuing.
So echo was done. Echo was found to be normal.
So that's the subsequent view of the fast, where you're looking for basically anything suggesting cardiac tamponade, an absence of a hypoechoic band around the heart. The absence of it says no cardiac tamponade. Next, looking at the right upper quadrant, again you're looking for a black strip, which is a hypoechoic area. So here, basically, you're not trying to rule out abdominal trauma. Here, what Tilak is doing is he's ruling in a hemoperitorium as the cause for the hypotension. The right upper quadrant seems normal. However, on the left upper quadrant, when you're viewing, you're seeing a large hypoechoic area, okay, both above and below the diaphragm. That's a mirror image what you see. So definitely there is fast is positive in the left upper quadrant. So minimally positive around the bladder also you're seeing some hypoechoic areas. So essentially fast is positive. So what do you infer from it, Dr. Tilak?
So since we found that source of the bleeding from the abdomen, and since patient is a transient responder, we should like already we initiated the warm IV steroids, but there is no improvement in the patient's blood pressure. So we initiated the O negative blood, and so we.
So take over, Hari Prasad. In the few minutes that you have looked at the abdomen and said that intra-abdominal bleeding, and now you have identified that there is blood in the abdomen, cause for hypotension, and also what is that you initiated as an active measure?
So like Dr. Tilak was mentioning, now that the warm crystalloids were already given, I think beyond 1 liter, you have to replace blood with blood. No point giving further crystalloids. And then here we go back to an important concept called permissive hypotension and hemostatic resuscitation, where giving too much fluids can actually dislodge clots and dilute the coagulation factors. So you have to replace blood with blood. So initially you can go for O negative blood because sometimes grouping cross-matching takes time, followed by cross-matched and group-specific packed cell transfusion. But one must also remember that when ongoing bleeding is there, you should have a backup of fresh frozen plasma and platelets as well. So good communication with blood bank goes a long way. So this was initiated, and then general surgeon was already on the floor with us So they plan to take the patient to the operating room. Meanwhile, Tilak?
So,
He's been having issues.
He's been having issues, so we
patient was
apologize.
intubated as we prepared verify and
Slow down,
so
Tilak. Slow down.
we
Yes.
so let
No, it is breaking up. So I think you should take over.
Yeah.
so induction
Okay, so like Dr. Tilak, what he's trying to say is that meanwhile the patients got intubated. I think a logical or a safe choice here would be injection etomidate. You have 0.3 to 0.8 milligram per kg. So we chose to give about 18 milligram of etomidate for this patient as induction, and for paralysis, 1 to 1.5 kg dosing milligram per kg dosing of succinylcholine comes out over 100 milligram for this patient was given. Patient was intubated, CL2 on laryngoscopy with adequate preparation. Patient was intubated, connected to ETCO2 and confirmed by 5-point auscultation. There was good waveform. Patient was connected to ventilator. Meanwhile, disability assessment was continued, and the team found that again here, just before ongoing paralysis was initiated with vecuronium 6 milligram, the GCS was E2, VT, and M4. Pupils continued to be reactive. Neuroprotective measures were initiated here. What's important is, again, use of an anti-epileptic drug. So because you're paralyzing with vecuronium, you may not notice a generalized tonic-clonic seizure. So administering it preemptively goes a long way. Appropriate ventilation, as we discussed in the previous case, as rightly pointed by, I think, Dr. Raghunandan also said the same thing. And managing the hypotension becomes very important. So you can only protect the brain by ensuring at least a map of 65 millimeters of mercury. In this case, again, we won't use vasopressors. We have a hemorrhagic shock, so we will go for packed cell transfusion, just enough to get us to feel the radial pulse. That is adequate perfusion for us. Coming to environment control, again, very important here. We notice some deformity and there's some swelling below the knee, bruising over right side of the abdomen, which again correlates with our finding of blunt abdominal trauma. Again, importance of maintaining normothermia for these patients is reiterated. There is something known as a lethal triad of death in trauma, that is acidosis, coagulopathy, and hypothermia, each worsening the other. So cut off this triad by make sure that hypothermia is not set in, manage the acidosis and manage the coagulopathy. So we use an external warmer and put the AC off. Ma'am, anything?
So, no, go ahead. Then this patient, yeah, go ahead.
Yes. Okay. So again, so here clearly in summary, we were dealing with a patient who had airway compromise, which was adequately well prepared and dealt with. But the hemorrhagic shock is not fully dealt with. We have managed currently with blood, but the definitive care would only happen in the operating room. So at the level of circulation itself, we don't move to the secondary survey as with the previous patient. The patient goes to the operating theater. So what's important here is, for a long time, what was always thought about, or more studies was done on anatomical difficulty. But today, thanks to video laryngoscopy, fiber optic techniques, more and more training, we are seeing more difficulty with physiological difficulty has become a larger concern, or an equal concern, I would say. So what are the things which cause physiological difficulty? It is hypoxia, hypotension, right heart failure, right? And acidosis are the potential physiological difficulty airway. Here, we had a pre-intubation hypotension in this patient. It is always said, resuscitate before you intubate. But in patients of trauma, everything has to happen horizontally. We don't have the luxury of resuscitating and taking time, because airway management is preemptively, it has to be done as soon as possible. So managing the shock becomes very important with appropriate preload optimization, early blood transfusion, and plug the leak. So plugging the leak becomes very important. Until you do that, post-intubation, you will see catastrophic cardiovascular collapses occurring in these patients, because no matter what induction agent you choose, you will see some deterioration. I think, ma'am, you can add on, even with the safest ones, once you give an induction agent, you will see a drop in blood pressure. So preparing for it and managing the hypotension becomes very important in this situation. Ma'am?
Yeah, I completely agree with you. And whatever we might say, the safest is the induction agent And if you see the maximum sympathetic response is already there, and in a patient who loses consciousness, you hit that sympathetic response, and you will see that there will be a fall in blood pressure. So in this situation, it's always best to not to go on putting in more and more fluids, which is going to get reflected back in the ICU in a patient whom you did good resuscitation in the ED and probably in the OT, but had many issues and had a white lung in the post-op, is going to be a problem. So the main thing in these patients is going to be, if the patient is conscious, a polytrauma patient who is got anatomical or physiologically difficult airway, which we have identified, then if the patient is conscious and requires a definitive airway, if sedatives and analgesics are going to be used, then it should be done very cautiously. Again, we have to have help on hand, and if you have a spontaneously breathing patient who is stable, then pre-oxygenation is mandatory. There is always time for you to wait for help to arrive in the place that you're going to be intubating. And it is best not to attempt with, and if you are not too experienced, it is best not to attempt the endotracheal intubation. So until the expert arrives, because the patients can deteriorate rapidly if there is a failure in intubation. So these are two things that we are looking at in before we intubate. But if the patient is hypoxemic, then we should maximize our approach in oxygenating the patient. We have to have an open airway, try to open the airway and ensure oxygenation is provided. Whether you're giving a high flow oxygen, you're doing an NIV, or you're going to do a bag mask ventilation with the cricoid pressure because the stomach is full, we have to ensure that the oxygenation occurs in these patients. And then you also have to ensure that the extent of anatomical injury is evaluated. And if it is very massive injury, then we might have to go in an early surgical airway for this patient. So ensuring that the appropriate masks are chosen and you're able to ventilate and you have help on hand, and call in both the surgeons or the ENT surgeons in case you are anticipating a difficult anatomical airway early to get the cricothyroidotomy done in this patient. And then, of course, it can always be changed over to a tracheostomy in the OT. But the most dreadful thing that we have seen in most of our polytrauma patients is the physiological difficult airway, where patients crash even after intubation. So we don't usually wait for these patients. We intubate early and shift them to the OT so that, as Dr. Hari Prasad said, you need to plug the leak. Whatever we do, we might not be able to hold it long. And when we start with O negative blood, it is just to buy time. As soon as the cross-match blood arrives, then we start off with the cross-matched blood. Anything you want to add for the pregnant patients, Dr. Hari, in case they come and you need to give O negative blood?
Yeah, so in a pregnant patient, three things that you need to remember is number one, always it's full stomach. So in airway management, a lot of caveats. The respiratory mechanics are different. Number two, when administering blood, if you know the RH status is important. If you're not known, administering the ROD immunoglobulin goes a long way. So coordinating with your OBG team, so they become a part of your trauma team very early on, because we should not forget there are 2 lives at stake. So you're resuscitating the mother. At the same time, while you're doing that, you're also ensuring the oxygen delivery is occurring to the fetus as well. So consider that, involve them in the trauma team early, provide tilt to the spine board to the left lateral position by putting a wedge under the spine board. This will ensure that the gravid uterus is not putting a pressure on the inferior vena cava and ensure adequate preload. So optimizing preload, providing wedge, good safe airway management, and your chest tubes have to be 2 space higher up because everything is pushed upwards. So a lot of caveats when you're managing pregnant patient, but again, involve the gynecologist early, make them a part of your trauma team. It should not be that once the patient goes to the ICU that they get to know. So again, it all, if you think about everything, just comes back to your trauma team and how well you're able to call for help early on. So I think that's a quick summary. Ma'am, we can add anything.
Yeah, I think that covers most of it. It does not matter what type of fracture it is or what type of injury it is. Main thing is we are not able to maintain the patent airway, so we need to have the experts with us to actually optimize care for this patient early. So anesthesiologists play a pivotal role in this part, and the emergency medicine works closely with them. And when help is called, nobody can refuse.
True, ma'am, true. A quick sample history, I think nothing more to add as far as the symptoms and signs are concerned, what we have already mentioned. Again, the patient came in pre-communication. There was no witness seizures. Patient was not. So again, this becomes very important even in a trauma patient, which we constantly look away from. So the sample history need not be that the team leader takes it. I can always delegate that task to a junior doctor to collect from the bystanders or from the family. So ask them for allergies, ask for medications, past medical and surgical history, last meal, liquid urine and stools. If you can get that information, but however, in this patient, we did not know that. But it's important to consider all of them. Events preceding also are very important. Sometimes patients go to multiple hospitals where multiple fluids are administered. So it's important to get that history. Again, ECG is also an important adjunct of the primary survey. However, as was previously discussed, you wouldn't want to interrupt key interventions just to get the ECG, but eventually that needs to be done. Sinus tachycardia here. X-ray, very important in this patient. Post-intubation, we have seen that. Again, you're confirming at what level the endotracheal tube is placed. You're looking at the lung fields, looking for rib fractures, hemothorax, any small pneumothorax. Looking for, what we always forget is to look at the diaphragm. If you've placed an orogastric tube, also look at the position of the orogastric tube. That's basically the external devices. So going in a logical sequence of airway, bones, C for cardia, D for diaphragm, E for external devices, and F for fields. The fields come last because our mind first goes to the lung fields. We forget to look at the other things. So going in a logical sequence goes a long way. Again, look at the blood work as relevant. Again, here we have metabolic acidosis owing to the hemorrhagic shock. We expected the anemia. Again, reassessment is an important component of primary survey. Constant reassessment has to happen. So this is where the team leader really plays a strong role. As and when interventions are being done, the team leader takes the feedback in a closed loop format from all of the key players as to how, so once the patient is intubated, so he would probably ask the airway operator, are we seeing a good ETCO2 waveform? You're auscultating, checking the chest X-ray, performing EFAST, again looking for the response to the packed cell transfusion. And here also a smart thing to do would be to obtain a CT brain en route. So even the anesthesiologist would want to know before anesthetizing someone that are we really dealing with a major traumatic brain injury which also needs intervention, or is it just the blunt abdominal trauma? However, we only saw contusions and pneumocephalus. So the focus completely shifted towards the blunt abdominal trauma. So this was our case, how it unfolded. Again, I apologize. Dr. Tilak had some issues with the signal, but I feel we were able to cover up. Again, thank you for the opportunity. I say thank you to the chairperson, Dr. Arna ma'am, and the entire team. We are open for questions and comments from all of you, please.
So I would like to thank the Honorable Secretary and also the ISA for this opportunity for our team to be a part of this. It brings back memories of OR and also that we are not far from it. Thank you for this. We are open for questions.
Thank you, Aruna ma'am, and thank you, Dr. Hariprasad sir and Dr. Shruti. It was a wonderful presentation, and thank you for covering up the technical glitch. And if there are any questions, people can raise their hands or post them in the chat box. Or if you would like to ask some questions, ma'am, to the audience, maybe they might like to reply in the chat box.
So the question is, people can raise their hands if they have trauma team at their center, and is there a trauma code that is usually called when red patients arrive in their ED? Also, if anesthetists are participating in the airway management in their hospital.
I think it's a difficult question. Anyway, somebody has raised hand. Okay, Dr. Ramachandra Reddy. You can unmute yourself and you can ask the question directly.
Madhuri ma'am has raised hand. Yes, ma'am.
No, I think somebody else was going to ask, no?
Yeah,
Is not able to ask. Shall I ask?
Yes, please.
Shall I put in my? No, there's not a question. Just an input that few days back we had an interview for our newsletter, The Vapor, with Dr. Nasir, the inventor of the iGel. So when we were like, what sir added inputs is that iGel, like as you already said, that supraglottic airway devices can be used as rescue airway management devices even in the pre-hospital setting. So in the discussion, he had said that nowadays, like even the soldiers, they carry the iGel in their rucksack bag. So every soldier carries the iGel in his rucksack bag. So if there is a trauma, if there's a polytrauma, so and if resuscitation has to occur on the field, then they very quickly pass the iGel. So they pass it blindly. And then we had asked that what if there is trauma, you're going to pass iGel blindly, and then there is no chance of trauma, of course, with the iGel because it is so soft. And regarding intubation over through the iGel, what he was saying is you can use the iGel Plus. The iGel Plus is it has got an intubation ramp, and over that you can intubate. And he had added one very good sentence that even if the patient aspirates with the iGel and the lungs become messy, at least you're going to avoid hypoxia. So instead of having a messy brain, you can have a messy lung, which you can probably treat later. I just wanted to add this, like regarding the importance of the supraglottic airway devices.
Yeah, definitely when you are on the field and you have no option, and that's the best that is on hand, I think anything we would go to get the hypoxia attended. So he just opened the
Yeah,
airway.
ma'am, Dr. Madhuri, ma'am. So as you were mentioning, a lot of the data and many of the guidelines have been obtained through military medicine. So
Yes.
US fought so many wars back to back. Most of the things we are following, especially permissive hypotension and hemostatic resuscitation, including the lethal triad of death, all this got derived from data from them because only they got this huge pool of hemorrhagic shock patients, and including protocols of massive transfusion protocol, use of one of the things that Aruna ma'am, one of the programs that ma'am is leading is the active bleed control. There we talk about the combat application tourniquet or the CAT. Even the
Yes.
CAT, its invention and its usage, a lot of it came through combat medicine. So it has helped a lot in all areas of trauma.
I think there was one question that was asked Is it ABC or CAB? That's what was asked. So if at the offset, when you look at a patient, if there is obvious bleeding, somebody has to actually put a compression bandage on that, and we go on managing the airway, breathing and circulation.
Regarding this, ma'am, all the formulation of guidelines and the protocols, because the emergency medicine has been growing in the institutions, not in the peripheral hospitals, whether it's anesthesiology, emergency medicine, now being overtaken by the trauma medicine.
Yes.
The new trauma medicine is coming. Very soon, the trauma will be overtaking many of the, I think, subset of patients which we are dealing in the emergency medicine, which were being dealt by anesthesiology previously. The most important part in our country and other resource challenged nation is the pre-hospital care. Because the trauma patients, it's always the golden hours, whether it's 30 minutes, 1 hour, 4 hours, 6 hours, there are so many definitions of different type of traumas and their golden hours. The system of rehabilitation at the peripheries, their timely referral, the availability of resources, the manpower, the skilled things, the alignment of the different courses, as well as the practical implementation of these services at the peripheral setup, they all depend upon the government policies, amount of fund available, how much fund you really allocate to the health resources. Till our country is the poorest of all when it comes to the allocation to health resources as compared to US. Almost there, almost one third is given to the health infrastructure and resources, and here we just get 3 to 4%. In these type of scenarios, I think whatever medicine branch you are trying to make it grow in our country will be having a rate limitation steps. You will not become to a completion because so much of the research is going on in different medical colleges, but that research cannot be complete till it imbibes all the limitations, the factors associated with the delayed arrival of the patients, their prognosis depends upon that, their morbidity, then the mortality. All these are because of the delay in transportation, time taken, the lack of knowledge in the peripheries, how to resuscitate properly in these patients, and what type of resuscitation measure they can take. Till there is a good coordination between these type of things, the policies come into play. I think we can have a very, very good trauma medicine and emergency medicine growing in India. Till then, I think we keep on working in our institution the way we are holding a webinar, seminar. It is good for our students. But in reality, if we really want to care about our health infrastructure, the health policies, and the safety of the patients, I think it's the people who the medicos should be sitting at the helm of affairs in the policy making so that real scenario can change drastically with the Western country. I don't think so difficult. It's not difficult. The only thing is the will. We have seen so many, I think, movies also. Suddenly, lastly, there was a South Indian movie I was watching where the entire, state was given all the blood transfusions and all the equipment within 5 hours just for keeping the CM in, custody. So that was just a joking, but the will and determination is definitely required to bring our these emergency medicine, trauma medicine, anesthesiology in, the holistic growth of these branches throughout the country. That's only I can give at this moment. But it was the best trauma people, emergency medicine people dwelling upon these things, very minute details of a trauma. Those are very much required for the PG students. Because even if you touch a trauma in anesthesiology, they will not give much details. Just see airway management, do like this, do like that. But what the pathophysiology, the entire scenario, what's the way to approach these patients, how you understand the pathophysiology, how you deal with the complications, what next? That is very important. I think that was very well taken by Dr. Hari Prasad and Dr. Forgetting name, the Dr.
Dr. Shruti.
Dr. Shruti Deshpande. This actually amnesia is setting in. That's why The problems are sometimes recollect the names also. So I think, and the students, they're fine, but I think all are growing under the guidance of Dr. Aruna Rebesh. And you have taken a good initiative in the growth of the emergency medicine in your college and as well as in your state rather. So it's a good initiative today, and it will go down into the, our history of our ISA classes, the trauma medicine and emergency medicine in a day with emergency medicine. We can label it like that.
Thank you, sir. Thank you indeed. I hope all the participants, anybody can reach out to us and to you, and we'll be able to actually talk to them and sort out any more doubts they have at any point of time. And everybody should undergo the ATLS course, I think.
Yeah, I think with the rather it's depending upon the policies of the councils also. The way our medical councils of different states have made it mandatory for the internees to get the degrees only when they complete these courses. I think rather than completion, ranking stress on the completion, they get it more practically so that it should imbibe in their curriculum. The way I was just looking at the ultrasound, see, the ultrasound in the last 1 decade has made a tremendous progress in the regional anesthesia, in the airway management, in the other things. But still, it has to find a good portion into the textbooks. Till you get to the textbooks, nobody can make it at much advanced. Our teachers, they are not well versed with ultrasound technology. You have to have refresher courses, the complementary and supplementary, as well as emergency courses for the teachers also. Till you get a proper ultrasound teaching at that level, because they will as a professor and head will say, oh, okay, AP, the assistant professor is well versed. Okay, you take the class. I am not well versed with it. But it's not, you can't shut off your duties. It is the education has to be imparted in a wholesome manner from the teachers to the students. So the new technologies have come. Ultrasound is a very, very great, you know, what you call as a technique in the hands of all the emergency medicine, the intensivist and anesthesiologists. But considering all the PNDTX and other things, it has to find its way into the textbooks so that even the government has to allow it. That will be very easy because once it comes in a textbook, you can always quote, you can always give the example to the court of law. That ultrasound is very important. Just don't consider about the PNDT Act. It is very much required for the safety of the patient, for the growth of our medicine, and for the, I think, betterment of society. Those things are also very necessary.
I completely agree with you, sir. But the residents need to understand where they need to draw the line and when to use the ultrasound.
Yeah.
Because they should not forget about the airway and then use the ultrasound in a polytrauma patient. Yeah.
Teacher has to make the understand. A teacher has to make them understand. Unless the teacher should know where to draw a line, the student will never know. A teacher has to tell them properly in a strict manner also. Nishant, you want to say something?
Yeah, thank you, sir. This is for Aruna, ma'am. Just a little query that I've always had, ma'am. It was a very nice session tonight. Ma'am, for a trauma patient, what I was wondering, like in all ATLS guidelines, they say that supplementary oxygen must be given. And you have mentioned also in your that high flow nasal. Ma'am, what is your take on high flow nasal oxygen in a patient who's come with trauma, probably a panfacial trauma, nasal trauma, maybe? Do you think it is we can give it safely in these patients?
The question is hypoxia is going to be more dangerous than anything else. So what the current thinking of polytrauma is, even in head injury patients, if they have over 94%, we might not be so concerned about oxygenation of the patient. But still, nothing didactic has come out of that. Still, the studies are going on. Nobody knows about the complete effect of this in a polytrauma patient. So what we say is, if the patient is hypoxic, give oxygen. If the patient, you are not able to open the airway, you think the patient has C-spine injury, go ahead and do the head tilt and ensure that you do get an open airway and you are able to intubate the patient, because that might be addressed. But if the patient dies, then or he becomes a vegetable, then we are in a more dicey situation. So we should always go ahead and try to address the hypoxia and try to ventilate the patient in case he becomes hypoxic before we take the next steps.
Yeah, Nishan, that's actually good query. What I was thinking after the query is, I also thought that in the final examination, we are following the long time, the long cases, the short cases. When you are having a surgery and a light, the NSCs are coming in the light sciences till date in the undergraduate curriculum, even though the NMC started taking it seriously. I think in all these examination now, instead of the elective cases, now emergency cases should always be kept. Whether you know a case scenario may be there, sometimes so that the student should be able to understand the psyche of the patient, psyche of the medical student, psyche of the teachers, how to answer those things, how to deal with those scenarios. Because otherwise it's just a ratification of the things. You just mug up the things and you vomit it then the examination. Dealing with the real practical scenarios, putting a case scenario in the final examination, although it's a virtual, you can have a video recording also, you can stop at certain time and you can ask the student what next you can do. So these things are the good things. If you can, we can bring the changes in our examination pattern also. I think even if not the final, at least when we are teaching our students, PG student during anesthesia curriculum or emergency medicine curriculum, we can always have the pre-final, the other examinations keep on going throughout the year. So we can always have these so that they can pass out with these type of things. Plus, the undergraduates, they are more important. So I think the undergraduate should also be the part of these teachings. We can have our own teachers, we can spare time, we can develop some in our own institutions rather than waiting for a central body to make guidelines or formulate guidelines to teach these things. In our own institution, we can always spare at least 1 hour in a month for these type of practical scenarios. And I think these type of questions will be very well answered at that time by the people who will be teaching those things.
Yes.
Right, sir.
Actually, madam has explained so nicely. The madam's team has explained so, a wonderful job, and the students, okay, they supported them. I don't think so. People will be having many questions today to ask the teachers. बस वो है उसमें वो एक उसका think about that Munna by MBBS. Is it a file necessary to make a file to attend a trauma patient first? Is it necessary to make file first or to attend the patient? I think that's what, because in the majority of time the patient is lying on the road. People just pass by without taking care because the police personnel, that police thing is everybody is scared of. And somebody passing, my car will get spoiled with all type of blood and the debris there. So people just try to run away from the site rather than helping the things, and they all make a huge circle around the patient, because even stopping all the oxygen coming to the patient. So these type of awareness has to be there in the public also. How to deal the patient. Maybe a hospital is just a yards away. A multi-specialty hospital is just a yard away, but people will not take that patient to the hospital. The rules and laws of the lands are so much, confusing and not helpful, not, I think, citizen friendly, that people will, volunteer to take those patients to the hospital for a primary care. That's a very important part also. Yeah, Doctor.
With the good cemeterian law that has come in, they have said that any lay person who actually helps a trauma victim will be given rupees 5,000. I don't know how much is true of that, but
So,
the government has announced.
That can happen in opposite to somebody forcibly hitting someone and taking to the hospital just to take 5,000 rupees. Yeah, Dr. Madhuri.
Yeah, I just wanted to add that the establishment of trauma centers in medical colleges along the highways on the Golden Quadrangle, that has made a major difference in improving the trauma management. Because when these trauma centers were established, they made a huge difference to the management of trauma occurring on the highways. And with these trauma centers, not only patient management, but even medical college students, especially those in anesthesia, orthopedics, all of them, they got better training to deal with trauma cases. And the government gave a lot of equipment also, like USG machine and all other machines, which helped in the management of these cases. And
But
in
that is,
our
but Dr.
casualties,
Madhuri, that is not uniform. Actually, it varies from state to state. It varies from
yeah,
place. place also.
Agreed.
But I think that is the first step was accomplished by the starting of the trauma center, starting of the emergency medicine courses, the trauma courses, even trauma DM. It's a good thing. But
Yeah.
ultimately, the second step is to be very, very important, where you involve the entire, peripheral health setups along with you. You have a
Yes.
close connection, the close loop association with those things. Only then the first step is okay. First step we have taken. I think every state has made, every medical college now they are having good emergencies and trauma care. But in the long run, it always a good coordination between, the first attendant, the person who's
Yes.
dealing with the trauma. Majority of the trauma we have seen in my state, the ambulance people are dealing with them. The ambulance means they may not be well equipped with the ventilators also. They may not be well equipped with the first primary source management strategies as well as equipment. But when they deal with this patient, they just carry them to the nearest hospital where they are paid to bring the patient. I think
Yes.
that is there are so many factors associated with bringing up the branch. It's
Yes.
not just the government. I think the multiple limitation at every step. The first step is taken, but the next 2, 3 steps, if we take, I think we can always come at par with the Western countries also. That is not a big
Yes.
issue.
Yes, agreed fully. Training of paramedics and all those people will make a huge difference.
That's one thing that Dr. Hari Prasad actually mentioned, the active bleeding control program that has actually brought into India. It is Stop the Bleed that is established in Western countries after the military bleeding situations, and also the mass shootings that killed many patients, brought in the Stop the Bleed program in US. The same thing was brought to India by University of Pennsylvania, Dr. Vinay Nadkari, and also the Pedistar and 108. They have brought, it is a very simplified program where we teach them that first thing is when a bleeding is there, how to actually do the compression, how to do a wound packing in case it is not controlled by compression, and then go beyond and teach them how to put a manual tourniquet or a commercially available tourniquet for these patients to stop the bleeding and shift them to the hospital. We do a lot of training for the lay people, and also the training kits are also very simple, which we can actually share with you, sir, and the medical colleges can take it forward.
Yeah, madam, I think it's a time to
Yes.
honor our guest faculty today.
May I request you, sir, to kindly present the certificates to the presenting PGs and the faculties?
Yeah, is my screen visible?
Yes, sir.
Yes.
Ma'am, we are so much delighted to have you on the board today. So many concepts got cleared, so many things got cleared. The trauma we have got almost into the tissue level to see what's happening there and how to deal with those. We are really grateful to you to chair this class today. So it's our small, gesture from our side, from the ISA National, the certificate of participation to you.
Yes, sir. Thank you. Thank you very much.
Welcome, ma'am. Dr. Hari Prasad, you were very good in combining the thing, helping Tilak also, apart from creating a good, the circumstances to make the thing better for everyone to understand. And your knowledge really helped us getting the good conduct in the class today. So we thank you very much for the
Thank you, sir.
participation.
Thank you, sir, for the opportunity. Thank you, ISA. It was
Most
wonderful.
welcome. Then Dr. Shruti Deshpande, sorry, I just it escaped my mind your name at that time. I should not have. So we are again indebted to you for being a good moderator for this class. And I think your pediatric knowledge will help us in the further. You will be taking part in the further academics of ISA where the pediatric issue will be coming. So thank you, Dr. Shruti.
Thank you, sir, and thank you for giving me the opportunity to become the moderator in this session.
Dr. Anjali, it was a good presentation. You were really, I think, thanks to your teacher, Dr. Aruna, ma'am, so make you so much of, a good presenter. I think you have almost passed the examination today before even appearing for the final examination.
Thank you, sir. Thank you for giving me opportunity to present in this such a great understanding.
And Dr. Tilak, I think you got little nervous, but your senior teacher, Dr. Hari Prasad, he was very well behind you. And it was good because presenting on a national platform is not an easy thing. And definitely you will get more opportunities, and you did a wonderful job in spite of getting a little bit nervous. Thank you, Dr. Tilak.
Thank you, sir. Thank you so much.
And today Ira has handled everything very well. So Ira, you have graduated to the next level of our moderator era now. So as a coordinator, as a moderator, you have advanced to a next level of our ISA online classes. Thank you, Ira, for part
Thank you
of
so
this.
much, sir. Thank you.
And Vedavani, you did a very wonderful job. Proud of you, and because you volunteered yourself to do this class, and it's good because exposure to the national classes and even coming to the national screen, and it makes you very confident in the future also. So good work, and we will be looking forward for more participation from your side in the coming days.
Thank you, sir.
So this was a part of felicitation from the ISA national side. And anybody wants to give any concluding comment before we finally close this class? Anybody can give? 2-3 minutes are there.
From us, from Ramaya Emergency Medicine Department, Ramaya Medical College, from the faculty and the students, I think this exposure has not only exposed them to the culture that ISA has in the teaching programs and reaching out to students across the country, but I think we in emergency medicine who are taking baby steps, it gives us an insight on how to take it forward and also to participate more widely in the future sessions where emergency medicine and the anesthesiologist can come together for better learning. I think if an opportunity is given for the postgraduates, also from emergency medicine to log on, sir, you can send us the link and then we will be able to send it to all the emergency graduates across India so that they can log on to the sessions every Monday.
Yeah, ma'am, these classes are available on ISA NHQ at YouTube. Plus, every Monday we are having these classes at 6:30 p.m. Today we had on a Tuesday because yesterday it was Christmas Day. So we did not want to disturb anybody for the celebrations of the Christmas. So, but it's on almost every Monday at 6:30 p.m. The link we can add you into the postgraduate also. We can add into our ISA groups so that they can circulate the links among them. And I will add you also into one of the groups, ma'am, so that you can keep getting these type of messages, class messages every Monday. We circulate 2 to 3 times per week so that everybody gets ready to spare time in on the Monday.
Thank you, sir. And thank you for this great achievement of what you are all doing. I think it's wonderful.
Ma'am, it's a teamwork. Actually, myself alone cannot do this. Madhuri is there, then Nishant is there, then people like Ira and other people are there. Navedavani type of people are coming and become as a huge team. And later on, I think this huge team will be involved in many other programs also. Projects are also coming up. The ISA dream projects are coming up in the next coming year. So many academic. We will be enrolling you, ma'am. I have noted down. Your number is there, that Hari Prasad number and Dr. Shruti's number is there. So I will be in touch with you people for the next few months also to keep in touch with you so that there are many opportunities actually. Can't mention at the moment, but we'll involve you definitely.
Yes.
So Ira, it's a privilege for you to close this session today because you being a senior moderator, you can close.
Definitely, sir. Thank you so much for this opportunity. And I thank you all for this enthusiastic participation and a great discussion today. Wish you all a very happy new year ahead. And thank you and good night.
Yeah,
Long live
Dr.
ISA.
Yeah. Always end up by say long live ISA.
Long live ISA, sir.
Happy New